Hi everyone. Today I am going to discuss about breech delivery. I am M. Sasi, working as an assistant professor in Tribhulam College of Nursing. Objectives: the students is able to understand the definition of breech presentation, narrate the types of breech presentation, explain the types of vaginal breech presentation. Introduction. A breech birth is the birth of a baby from a breech presentation, in which the baby exits the pelvis with the buttocks or feet first, as opposite to the normal head first presentation. In a breech presentation, the lie is longitudinal and the podalic pole presents at the pelvic rim. It is the commonest malpresentation. Definition: it is a longitudinal lie in which the buttocks is the presenting part with or without the lower limbs. A breech birth is the birth of a baby from a breech presentation in which the baby exits the pelvis with the buttocks or feet first, as opposite to the normal head first presentation. Incidence: 3 to 4% of fetus present by breech at term, 5% at 34 weeks, 20% at 28 weeks, 20% diagnosed initially in labor, 3.5% term singleton deliveries, and about 25% of cases before 30 weeks of gestation undergo spontaneous cephalic version up to term. Now we are going to see about the types of breech presentation. The first type is complete breech. The normal attitude of full flexion is maintained. The thighs are flexed at the hips and the legs at knees. The presenting part consists of two buttocks, external genitalia, and 2 feet. It is commonly present in multipara. The second one is incomplete breech. Incomplete variety with procedentia. One or more little parts, foodling knees, precede the buttocks. Sacro-anterior positions are more common. The sacro-posterior, as in the first, the concavity of the fetal front fit into the convexity of the maternal spines. Incomplete breech. First one is frank breech. It is breech with extended legs where the knees are extended while the hips are flexed. More common in primigravida. Foodling presentation. The hip and knee joints are extended on one or both sides. More common in preterm singleton breeches. Knee presentation. The hip is partially extended and the knee is flexed on one or both sides. Etiology: prematurity, factors preventing spontaneous version, favorable adaptation, undue mobility of the fetus, fetal abnormality, multiple pregnancy, polyhydramnios, oligohydramnios, placenta previa, pelvic mass. Diagnosis: clinical, the sense where by the palpation we can find out, sonography and radiology. By the way, we can find out the breech presentation. Vaginal breech delivery can be done by these three methods. The first one is spontaneous breech delivery, assisted breech delivery, and total breech extraction. Spontaneous breech delivery: the baby is delivered spontaneously without any traction or manipulation of the baby. This is commonly performed for very preterm babies due to their smaller size. Now we'll discuss about the mechanism of labor. The first one is delivery of buttocks. The engagement diameter is the biotrochanteric diameter 10 cm which enters the pelvis in one of the oblique diameters. Descent of the buttocks occurs until the anterior buttocks touches the pelvic floor. Internal rotation of the anterior buttocks occurs through 1/8 of a circle, placing it behind the symphysis pubis. Further descent with lateral flexion of the trunk occurs until the anterior hip hinges under the symphysis pubis, which is released first, followed by the posterior hip. Delivery of the trunk and the lower limbs follow. Restitution occurs so that the buttocks occupy the original position as during engagement in oblique diameter. Delivery of shoulder. Bisacromial diameter 12 cm engages in the same oblique diameter as that occupied by the buttocks at the brim soon after the delivery of breech. Descent occurs with internal rotation of the shoulders, bringing the shoulder to lie in the anterior posterior diameter of the pelvic outlet. The trunk simultaneously rotates externally through 1/8 of a circle. Delivery of the posterior shoulder followed by the anterior one is completed by anterior flexion of the delivered trunk. Delivery of head. Engagement occurs either through the opposition oblique diameter as that occupied by the buttocks or through the transverse diameter. The engaging diameter of the head is subaccipitofrontal, where it is a 10 cm. Descent occurs with internal rotation of descent with increasing flexion occurs. Internal rotation of the occiput occurs anteriorly through 1/8 or 2/8 of a circle, placing the occiput behind the symphysis pubis. Further descent occurs until the subaccipito hinges under the symphysis pubis. The head is borne by flexion. The chin, mouth, nose, forehead, vertex and occiput appearing successfully. The expulsion of head from the pelvic cavity depends entirely upon the bearing efforts and not at all on the uterine contractions. Sacroposterior position. The mechanism is not substantially modified. The head has to rotate through the 3/8 of a circle to bring the occiput behind the symphysis pubis. Next we are seeing about the assisted breech delivery. In assisted breech delivery, with a towel wrapped around the fetal hips, gentle downward and outward traction is applied in conjunction with maternal expulsive efforts until the scapula is reached. An assistant should be applying gentle fundal pressure to keep the fetal head flexed. After the scapula is reached, the fetus should be rotated 90 degrees in order to deliver the anterior arm. The anterior arm is followed to the elbow and the arm is swept out of the vagina. The fetus is rotated 180 degrees and the contralateral arm is delivered in a similar manner as the first. The infant is rotated 90 degrees to the backup position in preparation for delivery of the head. The fetal head is maintained in a flexed position by using the Morsia Smiley weight maneuver, which is performed by the placing the index and middle fingers over the maxillary prominence on either side of the nose. The fetal body is supported in a neutral position with care to not overextend the neck. Pepper force application. Uppers are specialized force used only for the aftercoming head of a breech presentation. They are used to keep the head flexed during extraction of the fetal head. An assistant is needed to hold the infant while the operator gets on one knee to apply the force from below. The third one is total breech extraction. In total breech extraction, the fetal feet are grasped and the entire fetus is extracted. The total breech extraction should be used only for a non-cephalic second twin. It should not be used for a singleton fetus because the cervix may not be adequately dilated to allow passage of the fetal head. In conclusion, the incidence of breech presentation expected to be low in hospitals where high parity births are minimal and routine external cephalic version done in antenatal period. Breech presentation can be managed by early diagnosis and effective management strategies by using different manuals and skillful observation of the obstetrician. Reference www.breechpresentation.com and Datta I have referred. Thank you everyone for your cooperation. Thank you.